Well, thank you everyone for joining me here tonight on a rainy Thursday evening. Hopefully the roads are going to be clear and everybody has power in their homes. Today's presentation is going to be on chronic mechanical neck pain. And I take it from the invitation that a lot of our fellow physicians here have some type of neck pain. So hopefully I can give you guys some tools to help maybe stave off some of that neck pain or treat some of the neck pain that you might have. For our session, I'd like to go over the epidemiology of neck pain, discuss some of the anatomy and kinematics of the cervical spine, then discuss some of the role of posture in how it affects our necks, and then look at some of the neck disorders that might be some of the sources of our pain. And then for the ENT population, some indications for ergonomics during your procedures, and also during computer work as well. And then we also have some speech therapists here too, so maybe some of the ergonomic considerations during swallow studies. And then for the hands-on portion, I would like to maybe go over some of the exercises and self-treatment and self-mobilizations. And so I'd like to narrow the focus down to mechanical neck pain, since there are quite a few other sources of pain, including cervical myelopathies, rheumatological conditions, connective tissue disorders, infection, malignancies, traumas as well. I would like to narrow our focus more towards the mechanical side. And then to a certain degree, cervical radiculopathies, I will discuss in its relation to more axial neck pain. Mechanical neck pain can be described as generalized neck pain that is nonspecific and localized to the neck. It can be derived from any structures in the neck, including the bones, the nerves, the muscle tissue, the ligamentous structures. And it is very difficult, even with imaging, to attribute any single direct source to your pain generators. That's why we have to look at a patient or you yourselves individually from a whole perspective of how you're moving, what areas hurt, and then maybe from a structural perspective if we have those available to us. In terms of neck pain, in the general population, the incidence in 1 year is about 10 to 20%. With a higher prevalence amongst women, and then there's a higher occupational risk amongst any office workers who are working on the computers, and healthcare workers have some of the highest incidences of neck pain. Computer and mobile device usage can increase your risk for neck pain as well. If you use your phone for more than an hour, you have a 1.4 times higher likelihood of experiencing neck pain. And then 1.8 times higher likelihood if you're using your phone for more than 7 hours a day. All of our phones have a screen time app, so I'd encourage you guys to look at it later and see where you guys stand. And then with computer usage, more than 2 hours, you can increase your prevalence, or incidence, sorry, by 1.5 times. Just in here, who uses their computer or phone for more than 2 hours a day? Whether you're charting, on the phone, everybody's hands up. Okay. Not by choice, yeah. Especially ENTs, you guys have fairly long notes as well. Yeah. I know. Yeah, I read Dr. Steenerson's notes, and they're these are massive reports, and it's so impressive. It's like, oh man. So then, in terms of the otolaryngology teams around the world, this study looked at and reviewed a multiple number of studies that looked at different pain areas for the ENTs. And neck pain has some of the highest prevalences, and throughout these studies it shows anywhere from 30 to 90% prevalence amongst respondents in terms of neck pain. This study was actually done here under the ENT department. I don't know if some of you remember the survey back in 2016 to 2018 that looked at ergonomics and pain. Amongst this study, amongst all surgical teams at Stanford, ENTs had the highest responder rates, maybe not by choice, but it gives us a good idea of what some of the common ailments that afflict you guys are. And you can see here, 31% of the respondents in the ENT department alone had neck pain at the current points of the survey, and lower back pain, only 6%. So pretty high prevalence of neck pain at Stanford. And then in this 2012 study, where they surveyed 476 ENTs across the country, looking at different musculoskeletal complaints during microlaryngeal surgeries, neck pain was the #1 complaint here. 52% of respondents had neck pain out of the 476 ENTs. In another study of 403 ENTs in Spain, the surgeons and physicians were about 45 years old with 17 years of practice. About 90% of the respondents reported experiencing some type of pain. 60% of them were lower back, and 50% was for neck pain. More interestingly, with this study, they found that 10% of the respondents actually had to limit their practice because of their symptoms. And another interesting response was that only 16% of the respondents had any awareness of ergonomic principles. With the Stanford study, they actually found that 76% of the surgeons who responded at Stanford had no idea about any ergonomic principles when it came to surgery, and that's a pretty large number. I have to save your necks so that you guys can save everybody else's necks. So I want to just quickly go over a little bit of anatomy. These slides have some pretty good classic Netter images for you to go back to if you wanted to review later on. So I won't go into too much detail when it comes to the anatomy of the cervical spine. This is the anatomy of C1, C2. You have the atlas on the left and then the axis on the right. With the axis and atlas, you have most of your cervical rotation occurring at this segment, and you can see through the Odonta process and the dens how the atlas articulates over the axis. And then you have C3 down to C7. C3 to C6 are more typical vertebra, with C7 being a larger vertebra that provides a little bit more structural support as it interacts with the thoracic spine. And then here are some of the ligamentous structures that might be culprits when it comes to some of the more scarier cervical myelopathies. You have the posterior longitudinal ligaments that might cause central canal stenosis. You have your transverse ligaments and alar ligaments that might be injured during traumas or might be lax due to rheumatoid arthritis or due to Ehlers-Danlos syndrome. And then here's another view of the cervical spine as it articulates and some of the ligaments attached to the cervical spine. And the images are pretty high quality, so you can zoom in later on if you want to reference back when I provide the slides. And then here is an image of some of the more superficial muscles of the neck. Of particular interest, for a physical therapist would be some of the muscles that are commonly painful, including the suboccipital muscles, the upper trapezius, the levator scapulae, the scalenes, and then the SEM. And I think some of these muscles are actually pretty important in your surgical practices as well. I think Dr. Orloff, with your neck dissections, right? The upper trapezius with the spinal accessory nerve can be a common injury site, right? And then some of the deeper layers of muscles and their attachments. that are particularly of interest for us as physical therapists include the suboccipitals here with the obliquus capitis muscles, the rectus capitis muscles, which are really important for rotational and upper cervical stability. And the deeper layer here, the levator scapulae, can be a very common pain source if you have mechanical neck pain. So going a little bit deeper into the cervical deep neck flexor muscles, they're considered the deep core of your cervical spine. For the lumbar spine, there's a lot of considerations for the transverse abdominis muscles in their ability to provide the micro instability for the lumbar spine. And in your cervical spine, the longest coli, the longest capitis, the rectus capitis anterior and the rectus capitis lateralis are very important stabilizers in ensuring the cervical spine maintains its cervical lordosis, and they're the primary antagonistic muscles to the very large cervical extensors, like your upper trapezius muscles and your paraspinals. When I discussed a little bit prior with the transverse abdominis, they both have roles in feed-forward mechanisms. So if you were to initiate any arm movements, the deep neck flexor muscles should initiate and turn on prior to any arm movements. However, in dysfunctional necks, they tend to be turned off. So, very commonly if you go to the gym and you see people weight training, if they're doing any overhead motions, benching, all of a sudden you see their chicken heads, like kind of cluck. It's likely that their deep neck flexor muscles are not activating and timing correctly. And then this is what they look like. They're very close to the cervical spine, so they're right up on the anterior surface of the cervical spine and on the upper cervical as well. In the physical therapy and rehab world, one of the important metrics for treating neck pain is actually deep neck flexor endurance. Think about this as the manual muscle test for the cervical spine. You guys can actually do this on yourselves as well and test and see where your deep neck flexor muscles are in terms of endurance. For the pain-free norms, women have tested at 29 seconds and men have tested at 39 seconds. When I have patients come in, I try and get everybody closer to 45 to 60 seconds in terms of endurance. If you wanted to try this at home, you just lay on a yoga mat with your phone recording you from a side view, and then you can perform a maximal chin to throat position and lift up by about an inch or so, and then record how long you can hold that position for. And once you see the folds of your chin lift off, or if your head goes higher or drops below that inch, the test ends, and then you can just time yourself on the phone to see where you stand. The cervical spine has the luxury of being the most mobile spinal segment. The normative values are pretty wide when you look at different studies. Cervical flexion can be anywhere from 45 to 70 degrees, 55 to 70 degrees, and lateral flexion, I think we have a little bit closer of a norm there of 40 degrees. Rotation is about 70 to 90 degrees. As a rehab specialist, we really want to encourage and correct movement, so we use these as kind of a guide to restoring our patients' pain and mobility. So the wide gap, maybe it could be explained by some of the age differences. With this chart here, you see from across the decades of 20 through to the early 60s right here, the cervical mobility declines pretty linearly in every decade. And then I think it'll probably, if this chart goes even further, decline significantly further going to the 70s and 80s. In terms of segmental movements, the cervical spine has most of the rotation occurring at C1, C2, if you crawl the atlas over the axis. And that should be about 40 or so degrees of rotation. Flexion, extension combined should be about, about 25 to 30 in the upper cervical spine. And then this chart here shows some of the measurements at the different levels as well. This is particularly important to us again because as we're trying to restore motion, if you have a dysfunctional level in your neck in terms of pain or mobility, that can limit your overall movement. And so from my perspective, I try and identify where a patient might be hinging or might be limited in their movements and try and understand that so that we can correct their movement patterns and reduce their pain with movements. And then in this graph over here, we have visualized the individual segments from the occiput all the way down to T1 and the movements that occur, the segmental movements that occur at each level. The top chart is the flexion extension movements at different levels, and then it's lateral flexion for the middle chart, and then rotation for the lower chart. And with the rotation, again, C1, C2 has the greatest amount there. And then this is a subject under fluoroscopy. You can see pretty clearly the segmental movement and the facets gliding on each other as the patient extends their neck. I got this from makeagif.com. And then, again, from a rehab perspective, from a PT perspective, we first observe active cervical range of motion, and then we look at how each segment is moving actively, and then I'll have the patients head on down into a plinth, and then I'll assess their passive motion, feeling segmentally where the motion's occurring, and then I'll use my hands to manually assess each cervical facet, transverse process, or spinous process, and see how they're moving as well. And then I can then use that as treatment. Here's a sagittal view of different types of cervical spine postures and positions here. I don't know if I've seen an S-shaped cervical spine. I don't know have you guys seen some of those? And then here's just an image for us to consider when, for our own selves, in trying to know what a good posture is. So the forward head posture is on the top left, and then a slight forward head lordotic posture in the right hand, and then the lower image is a very upright ideal posture where your ear falls right over the AC joints or shoulder. And then the scapular positioning is actually a fairly important consideration for posture as well. So understanding someone's shoulder position has impact on their muscle length tension when it comes to the upper trapezius, the sternocleidomastoid, and the levator scapulae muscles. At times I see my patients are either elevated or depressed in their scapula, and that can create increased tension on their necks if their upper trapezius muscles are too short or over-lengthened. Normative neutral position for the scapula, the superior angle should be about at T2. If you have a hard time palpating the superior angle, you can look at the spine of the scapula and then kind of go towards T3. The medial border should be about 3 inches from midline. The internal rotation, so that forward shoulder posture, some of it's normal. The scapula is around 30 degrees of internal rotation, and then about 10 to 20 degrees of anterior tilt and upward rotation. The thoracic spine also plays a pretty important role, given the cervical spine sits on the thoracic spine. Increase in thoracic kyphosis typically leads to an increase in cervical lordosis and forward head posture. The thoracic spine tends to be stiffer in kyphosis as well, so that doesn't give the cervical spine any leeway. Given the cervical spine is very mobile, there tends to be a greater breakdown in the spinal segments lower down. So C4 through C7 tends to see a higher incidence of degenerative changes and cervical radiculopathies. Some of the common radiographic angles to determine, forward head posture and kyphosis would be a T1 slope or a Cobb angle. And then here's a very classic physical therapy photo of the upper cross syndrome. I mean, I'm sure you've probably seen some of your colleagues in this position on the right, or even yourself in this position as well. With this very typical kind of forward shoulder, forward head posture, the deep neck flexor muscles tend to be over-lengthened and weak. And if they're over-lengthened, they don't have good cross-sectional connections with their muscle tissue. The lower trapezius and the mid-trap and the serratus anterior tend to also be over-lengthened and weak as well in this posture, whereas the upper trapezius, levator scapulae, and pec minor, pec major tend to be stiff with this posture. Here's another image kind of showing you what the muscle force vectors would be when you have a transition from a neutral head posture to a forward head posture. That SCM muscle, goes from a cervical flexor all of a sudden to maybe doing more depression or lateral flexion as your head goes forward. So you lose some of the muscle function or the normal physiological muscle function when you have this posture. In this study, the study looked at the loads of the head on the neck at different postures. And actually, who here knows how much an average head weighs? Any guesses? Yeah, there you go, 12 pounds. Yeah. So anywhere from 10 to 12 pounds is the weight of a typical adult's head. In a neutral posture where your spine is pretty upright, about 10 to 12 pounds of load is placed on the cervical spine. As you increase the forward flex angle, going up to 60 degrees, you might be looking down at a patient during surgery, and that 60-degree angle, your head all of a sudden is putting 60 pounds of load on your neck. And then you prolong that posture for several hours during some of your longer surgeries, and then you're going to not only get degenerative changes at the bony structures, but you also might get some physiological changes to the ligamentous structures and strain on the muscles. And then here's just another view of this with the angles depicted. Yeah, 60 degrees. I mean, you walk down the street, and I'm sure half of the people on campus look like that 60-degree image. And then here in this study, the lumbar spine loads were assessed at L4, L5. A pressure sensor needle was inserted into the disc at L4, L5, and then the subjects were told to lean forward up to 30 degrees, holding a 10 kilogram weight and no weight at all. And you see a pretty large increase in loads to the disc. Almost like a 3x increase in loads if you were looking at it from Newton's measurements on the lumbar disc. Some quick tools that you guys might use in clinic too, if you wanted to maybe assess a patient's forward head posture, would be to assess their craniovertebral angle. You could take a goniometer and place it at C7 for the axis, and then guide the arm to tragus of the ear, and then the fixed arm is horizontal. And if the subject or patient or yourself has an angle that's less than 50 degrees, it's considered a forward head posture. I think this is also pretty relevant too. If a patient might undergo, let's say, radiation, and they already have a forward head posture, it might be pretty hard to get out of that and correct whether they had degenerative changes in their neck or with the fibrotic scarring as well. Another quick measurement you can do for either yourself or for your patients would be to assess your thoracic kyphosis and forward hand angle using a wall. So with the occiput to wall test, you can just stand against the wall with your heels touching, your hips touching, and your shoulders touching. And if you were to maintain a forward gaze, you should be able to touch the back of your head, the occiput, against the wall. If you're about 2 centimeters off, you're still kind of within that norm, but anything greater than that, and it would be considered a thoracic kyphosis or a forward head posture. So with all that being said, what is like normal in terms of aging, right? Physiological aging, as it relates to the cervical spine, usually first occurs at the discs. As we age, our discs lose hydration, and they start to either deteriorate or they start to shrink, right? With the cervical spine, because of the lordosis, you have a larger anterior disc and then a smaller posterior disc to help maintain that lordotic structure. And so as you lose cervical height, you start to lose some of your cervical lordosis as you age. But not only that, as you lose disc height, the ligamentous structure surrounding the disc and surrounding the cervical vertebra become lax. And so then that can increase any shearing forces, increase any aberrant movements, which then over time will lead to loading on the facets, and that can lead to osteophyte formations. But again, most people will have these degenerative findings and not have any symptoms. I think one study showed that 80% of individuals might have this over the age of 40, and they're still asymptomatic. So then, what are some of the things that might cause neck pain? We'll go over that as it might relate to axial mechanical neck pain. So axial neck pain is localized to the neck region, and it's typically includes pain and stiffness, or maybe possible loss of cervical mobility or range. Again, degenerative findings are common and could be very nonspecific, so we wouldn't hang our hats on some of the imaging necessarily. We'll have to correlate the imaging with symptoms and with some of our other examination and tests. Some other sources that I wouldn't go over today would be rheumatological disorders, infections, malignancies, trauma. But as axial neck pain goes, some of the potential sources include cervical strain, which might be muscular ligamentous strains or muscular trigger points, cervical spondylosis, which is degenerative cervical spine with osteophyte formations, cervical discogenic pain, pain related to the disc, cervical facet osteoarthritis, which is degeneration of the facets or maybe the uncovertebral joints, and then radiculopathy. I had briefly discussed that I wouldn't mention radiculopathies, but cervical radiculopathies actually can contribute to axial neck pain when you look at the C3, C4, and C5 cervical nerve roots and their innervation patterns. So again, some of the muscular sources that I commonly see I come into my clinic include suboccipital pain. I see that quite a bit with any whiplash-associated injuries. The suboccipitals tend to take on a lot of strain. The sternocleidomastoid is also very commonly hypertonic and painful muscle. If someone had any specific high-velocity injury, that muscle might be in a spasm, along with the upper trapezius. The scalenes tend to be hypertonic, particularly on our patients who might be very anxious. They tend to be more of a apical or chest breather, so they would use their scalenes to breathe, and then these muscles become hypertonic and painful, which then can lead to any number of thoracic outlet type syndromes. The paraspinals can also be painful, as well as the levator scapulae and the upper traps. Again, with cervical spondylosis, it's a very common finding. I said 80% of individuals over the age of 40 have some type of degenerative changes. That number goes up to 85% of individuals at age 60, and they still could be asymptomatic. Some of these degenerative findings could be, related to disc bulging, bone spurring, and maybe hypertrophy of the facets. They all kind of fall underneath this cervical spondylosis diagnosis. The cervical facets are actually a very common source of neck pain and stiffness. As you can see here in this image, here are some very common cervical facet pain referral patterns. And C2 all the way down to C7 have some type of referral to the neck itself. With cervical facet pain, it's typically unilateral unless there are multiple segments that are involved. And then you tend to see pain more with end range motion. So, if you are, let's say, driving and then you're trying to check your blind spot and all of a sudden, you have a very localized neck pain, it could be muscular or it could be facet. And it could be related more to the irritation of the facet joints, facet capsule injury or hypertrophy, arthritis at the facet joints, or less common cyst formations that can occur there as well. Surprisingly enough, with cervical radiculopathies, facets degeneration and osteophyte formation around the facets tends to be more of a leading cause of cervical radiculopathies than lumbar facets degeneration. With the lumbar spine, it tends to be more related to any discogenic herniations that lead to the radiculopathies. And then with cervical radiculopathies, your C3, C4, and C5 dermatomes will innervate the neck. And I don't think we consider the radiculopathy as a differential when it comes to axial neck pain. Particularly of interest to me would be maybe the C2 radiculopathies that can also mimic maybe a occipital headache pattern. As I described earlier, the anatomy of the cervical spine lends the lower cervical segments to greater injury, given how mobile they are and how hypomobile the thoracic spine is. So C4, C5, C5, C6 tend to be the areas where cervical radiculopathies are the most common. And then going towards the cervicogenic headache patterns, actually probably of interest to some of the ENTs as well. With the trigeminal nerve, the afferents, as they return to the trigeminal cervical nucleus, actually intersect with the C1, C2, and C3 spinal nerves. And any pain along the upper cervical spine might also be referred to the trigeminal nerve as well in its innervation pattern. And some of the pain patterns would be around the parietal areas, the frontal, and the orbital regions as well. The prevalence of cervicogenic headaches in the general population is on the lower end. It's about 1 to 4%. But with individuals who have severe headaches, it's up to 17.5%. And then for some of the patients that come in and see me with head and neck injuries related to whiplash or concussions, it could be up to 53% of the population might have some type of cervicogenic headache. Cervicogenic headaches are secondary headaches, so they don't get a lot of love, compared to migraines. But in my practice, I actually do see quite a bit of cervicogenic headaches. This study looked at the injection of noxious stimulus at different interspinous levels. The arrows kind of point to the different interspinous levels, and then the numbers are the percentages of respondents that reported pain after injection of the noxious stimulus. And you can see with the upper cervical regions, quite a bit of pain referral that would go towards the head. So do consider the neck, the cervical spine when discussing potential headache patterns. And then this diagram shows another study where the subjects were injected with a noxious stimulus at the cervical facets and the disc, and then their subsequent pain referral patterns. And then over here, some of these patients got some relief. They were given an anesthetic block to C1, C2, C2, C3, and C3, C4, and they reported relief of their headaches after the injections. And the colored areas are where they reported relief from their headaches. if a patient has headaches and neck pain, you should definitely consider the neck as a potential generator as well. And just good practice to treat the neck and see if it might affect their headaches. For migraines, neck pain can be a trigger as well as any other traditional migraine triggers like food, alcohol, caffeine, stress. And then this is a pretty classic diagram of muscular trigger points and their referral patterns. If any of you guys do have headaches, feel free later on to go to this slide and then palpate around and see if you feel some of your headaches come on from the different trigger points. So then let's discuss a little bit of ergonomics. Everybody here uses a computer, and not everybody has the most optimal setup, unfortunately, whether you're in the clinic or in the OR or at home. But an ideal monitor height in an ideal world would be about eye height, maybe just a little bit, the top edge, a little bit higher than your eyes. If you had a sit-stand desk, adjust the sit-stand desk so that your keyboard tray is about where your elbow is and your wrist is in neutral posture. I actually prefer the seat just a little bit higher so that your hips are just a little bit higher than your knees. That allows you to control your pelvic and lumbar lordosis a little bit more to get into a neutral. And then I'm a big fan of armrests. So if you have a depressed scapula, let's say you have really long neck, right? Your upper trapezius, your levators are really long. If you have an armrest that isn't at an ideal height, those muscles are always on. For taller people in here, when you take long flights, those armrests are down by your thigh, right? And how do you feel after your flight? It's everything hurts, right? Your neck is really tense, and so if you have a long neck, get an armrest and then elevate the armrest just to where your shoulder is in a neutral position. You don't want it to be up here either, but elevate it to neutral. And then some surgical ergonomic lessons. I've not performed any surgeries myself, but there's plenty of research out there that has information on proper surgical ergonomics. And you can consider what we just saw on the previous slide, right? Look at this gentleman, and then look at this person looking at the monitor, their elbow height, and then the patient's height as well. Interestingly enough, surgical residents have a higher prevalence of musculoskeletal pain. And I think the Stanford study actually showed that surgeons who have fewer than 5 years experience, 88% of them reported experiencing musculoskeletal pain. And then when you look at surgeons who are in their second decade to more than 3 decades of practice, 58% of them might have reported experiencing musculoskeletal pain. But they're both still pretty high numbers on both ends. Some of the theories would be surgical residents might have higher mental and physical stresses due to learning new techniques and then having to apply them on the job, being less familiar with ergonomic positioning, increasing grip force with some of the practice, and then maybe actually having to perform some of the more strenuous tasks related to surgeries. I know Dr. Orloff, you actually you hook the residents up and you take the harder side, but sometimes with orthopedic surgeries, they might have the patient, crank on that thigh for an hour straight, and to try and get into the knee for a knee replacement. And so be considerate to the residents. And then again here, I'm sure you guys see this in OR every day. Someone who might be very forward flexed, leaned over a patient, particularly maybe certain procedures are worse than others. If you're leaned forward, again, you think back on that image with the neck. And then if you're rotated in any way, that can also produce more strain on your lumbar spine. So try and minimize your cervical flexion, neutral forearms, try and keep weight evenly distributed. Although I think having a plate on the ground for changing foot positions, if you're standing for a long time, might be actually pretty helpful. But a slight knee bend for sure, though. And then some of the surgical equipment that you guys might use, microscopes, being in someone's ear or doing something really like really small procedures, very precise procedures. Try and have the microscopes, at an angle where you're not having to lean too much into it. Maybe place the patient a little bit closer. Surgical headlamps. That can be a major issue. One study looked at surgical headlamps and found that high-frequency headlamp users had 68% of them reported experiencing neck pain. So, you can find maybe a well-fitted, well-weighted headlamp. That would probably be ideal. And then, actually, speaking with Noel here, prism loops. I didn't know they existed, but prism loops could be pretty helpful as well if it works in your practice. But I assume it might be very kind of jarring to kind of suddenly switch to practicing like that. And then in this review article, they proposed some strength and ergonomic training for cardiothoracic surgeons, which I'll leave up here as well. They include exercises for the core, for the back and the neck. And then today, whoever is interested, we can review some of the exercises that might be helpful for you guys for your neck in terms of mobility, and also exercises to help strengthen the neck as well. So in conclusion, ENTs have a high occupational risk for neck pain. An increase in forward flex posture can significantly increase loads on your neck. Optimal posturing and ergonomics are critical in ensuring longevity in your practice. And increasing your flexibility and strength and endurance can help you avoid disability. So before we practice, just want to put that out there. You guys all signed the waiver, I assume? Yeah, and then I have my contact information up here on the slides for you if you have questions, or if you have maybe patients you'd like to refer to me as well. And then I have some fun gifts and tools we can use if anybody's interested in practicing. But before we do that, are there any questions either in the audience or via the Zoom? I don't know actually how I would know. Maybe if you can, is there a raise your hand response or chat? Yeah, or any questions in the room here? Sure, Dr. Olaf. Yeah. Dr. Orloff had a question about sleeping posture, whether it was an optimal sleeping posture to help promote neck health or restore some neck health as well, if your work brings you in that forward flex posture. Do not sleep on your stomach. Sleeping prone is probably the worst for your neck because you're going to be in a rotated and extended position for prolonged periods, particularly if you're using a pillow. So that can produce increased loads on your facet joints. Sleeping on your side would be preferable, and then sleeping on your back would be second preferable. It all depends on your bed. So if you're a side sleeper, a medium firm bed would be ideal, as it will help to kind of distribute the load of your shoulders and your hips a little more evenly, so your spine is a little bit more neutral. Find a pillow that, when you're laying on it, prevents you from dropping into a lateral flexion, either up or down. So then in a more neutral posture. And if you have a really large head and small neck, you can put a little towel roll in your pillow so that it provides that little lordosis kind of support. And then that would be a little bit better for sleeping positions. I think we have a question in here. Thank you for the informative talk, Mike Chang says. Any thoughts on effectiveness of wearable technologies that can assist in posture and neck health, such as the Upright Go? I actually had an Upright Go, and I think, let's see, I used it for a little bit, and then I got annoyed by the constant buzzing because I was slouching. Dr. Santamaria gave me a box of these posture devices as well, and I couldn't get them to work because I don't have an Android. And then I think the app, the app has been updated, so it doesn't work for any old Android or new Android devices now. But if you're interested, I have a box of them. I can distribute some out later on if you just shoot me a message. So yeah, that would be the upright go. Yes. Oh, perfect then. Yeah. I think if you dial it in correctly with like neutral posture first, and then you utilize it for like, let's say, your practice, it could be pretty effective. Yeah, because it's more of like a cue or a reminder, to correct. It's impossible to maintain like perfect posture, like all the time. So taking breaks from like your upright postures to shift around is perfectly fine. And then having that cue, I would recommend taking a break every 20 minutes from like any position, just for 20 seconds. Now it might be very difficult if you're like in a surgery where anesthesia time is pretty like important and finite, right? But if you're charting, take a break every 20 seconds, look at something, or 20 minutes, and look at something 20 feet away for 20 seconds. 20, 20, 20. Okay. Yes. Yeah, that's a great question. A gentleman in the crowd just asked about what are some of the things that you could do for patients who might have an aphasia or might have difficulty with swallowing due to their forward head positioning. Some of the exercises that I have on here actually helps to train against that. If a patient is, let's say, like very forward head posture, it's going to take some time, yeah, because you're having to stretch out some of the structures, maybe ligamentous, maybe muscular, that have pretty much like trained itself into that position. So like being mindful of their posture and then slowly working towards a more neutral posture would be ideal. But I can imagine when you're in this forward head posture, your breath intake is different, your swallowing is different, right? So it would have a pretty significant impact on our populations of patients. Excellent. Can we do some steps? Yeah, of course. So I think we can see the plinth over here, and so anybody would like to follow along in the crowd, and I have some handouts as well. So if you guys want, and who wants to be a subject, or who wants to, you can totally do it on the table as well.
There's another question that came. Chiropractic treatment or physical therapy.
What was the first part?
For someone with poor.
Sounds like a trick question. I don't know. So I think there comes a time and place for chiropractic, let's say, treatment or manipulation, if it's combined with like strength training and postural training too. I think where we might fall into sometimes over-reliance is thinking that a chiropractic adjustment would resolve someone's pain. Well, what it does is it helps with like mobility in the spine. So if you had a locked facet, if you had pain, the manipulations can help to calm those muscle spasms down. It can help to calm any like mobility deficits or locked facet joints. So it has a time and place. And I also do manipulations. So, but it comes in time and place. So I think some of the exercises that we might be able to do in here are actually this right here. If you have a pillowcase at home, you can follow along as well. We have. Oh, sure, yeah. Here you go. Oh, as in like make it brighter or make it.
Just stop sharing.
Mm-hmm. Oh, okay. But they wouldn't be able to see the exercises, though. Yeah. We're going to practice exercise number 2, snags. So if you guys have a pillowcase, whoever has one, I have some towels here, too, if you guys want to use a towel. Maybe we can, let's see, pass them. There. Oh, yeah. Yeah, there you go. T-shirt guns. You guys need a towel for over here, and then I'll have one for myself. Okay, so exercise number 2 helps with that upper cervical mobility. So if you have any restrictions in C1, C2, if you have painful, let's say head turning, checking your blind spot hurts, if you're biking and checking your blind spot hurts, you can do this one. So let's drape this around like a cape or like you're at the hairdresser, okay? And then before you do anything, just feel what it feels like to turn your head left and right, okay? And then now take one hand, hold the opposite side of the pillowcase or the towel, okay? And then the other hand pulls straight down. So the up hand goes towards your nose, and then the down hand pulls straight down. Now pull firmly straight down, and then turn your head towards the side that's down. And as you turn, if you can't turn anymore, pull with the towel or pillowcase, and you should feel a deep stretch in the joints. Make sure it goes across your chin, though. There you go. So get it across the face. And then do 10 repetitions of that, and you should feel the facet joints. You might feel some like clicking, you might feel some crunchies, but you should feel a deep stretch in the facet joints. And then do it actively, so you're getting the actual articulation of the facet joint. Bring that ear down a little bit so you're not getting that lateral head, neutral. Yeah, there you go. That's it, that's it. Can you guys feel a deep stretch in the neck when you do this? Okay. And try not to turn your shoulders. So you want to lock the lower cervical spine, and you're only getting the upper cervical. Nice. And then the tricky part now comes with like switching hands. So put one hand, the opposite hand down, and then reach over. And so you're pulling across again. That's it. And then turn to the right. Ooh, yeah. I just got a nice little cavitation or little pop. Nikki here. There you go. Nice. Do 3 more. Good. And then for those who've finished, try turning your head again. See how that feels. And it should feel a little bit lighter. Yeah. Excellent. So then after you do that, you would want to train actively some of the movements, okay? So after training, after releasing it, just do good posture. So for most of us, let's see if we can like sit a little bit more upright. Okay? Shoulders maybe just a little bit up, a little bit back. Okay? And then in this position, retract your head so your ear is right over your shoulder. And then just do 5 head turns. Now, the facet joints are synovial joints. So when you move your neck, those facet joints release synovial fluid and self-lubricates. So if you don't move your neck or you're very stiff, it just, it's a downward spiral or cascade and it just gets stiffer. Here's another really great exercise that I love. For those in the crowd, I have a lacrosse ball here. Yeah. One for you. And then I give one for you. I got some extras. Who would like one? You answered a question, or you asked a question. I like. Who asked the question? You answered a question. You get one. And then maybe one of you guys can share one.